So it's now my turn to introduce Professor Beata Kos Kudla, who is chair of the Department of Endocrinology and Neuroendocrine Tumors of the Medical University of Silesia in Katowice, Poland. She is a specialist in internal medicine, endocrinology, and nuclear medicine, and is actively involved in education and training, both at home and abroad. She is president of the Polish Society of Endocrinology and a member of the advisory board of the European Neuroendocrine Tumor Society. And it's a pleasure to introduce Beata that will talk about the implication in all settings.
Thank you very much, Valentina, for nice introduction. And I will start with that presentation. Of course, first of all, I would like to thank you for this opportunity to share with you this information about future implication in management of pancreatic neuroendocrine tumors, based on the latest guidelines, European guidelines papers. There are my disclosures. After those beautiful presentation, which was given by Valentina, I would like to summarize from practical point of view the position of NETs expert who last year published 2 new guidance papers on functioning and non-functioning pancreatic neuroendocrine tumor. They were published in Journal of Neuroendocrinology. I will begin by discussing hormonally active pancreatic tumor, emphasizing that 70% of pancreatic tumors are associated with genetic syndromes, including MEN1, MEN4, NF1, and so on. A new guidance paper provides answer to the 9 most essential clinical questions. Let's start with the latest developments in diagnosing insulinomas. The current diagnostic algorithm emphasizes the differences or differential diagnosis of postprandial hypoglycemia, which is crucial in daily practice. It also highlights a new threshold for blood glucose level in the fasting test, which has been lowered from 3.5 to 2.5 millimole per liter. You can see in the slide. Additionally, after confirming biochemical evidence of endogenous hyperinsulinemia, the guidance underscored the role of endoscopic ultrasound, particularly for locating very small insulinomas, and recommends the use of GLP-1 receptor imaging when EUS results are negative or in the case of multifocal lesion. Due to the challenges in diagnosis gastrinomas, a new diagnostic algorithm has been proposed, especially partly related to the lack of availability of secretin for testing. This approach, as you can see on the slide, combines characteristic symptoms, gastrin level more than 10 times upper the limit, and gastric fluid pH below 2, to confirm a diagnosis of gastrinoma, of course, without PPIs. If a patient's gastrin levels are elevated by less than 10 times, we need to use alternative diagnostic consideration as outlined in this slide. Biochemical tests for rare functioning syndrome should only be performed in patients with specific sign or symptoms. And there is a need for genetic screening because I don't know if, sorry, I don't know. You can see this, our, I don't know if you see our faces. No. Okay, let's come back to the presentation. There is a need for also for genetic screening, as I already said that 70% of pancreatic neuroendocrine tumors are associated with genetic syndromes. Patient with hormonally active tumors, family history, symptom suggestive or any this syndrome should be referred for genetic screening. And from practical point of view, are there any differences in the imaging diagnostics for functioning and non-functioning pancreatic NETs? It's really important. The main differences is the use of GLP-1 receptor PET-CT, but it's worth to know that GLP-1 is overexpressed in 93% of localized insulinomas, but it is overexpressed in only 36% of patients with metastatic insulinomas. It means that for malignant insulinomas, we can use gallium PET-CT as a really good tool for this malignant insulinomas. Regarding update in the surgery, pancreatic sparing resection for insulinoma, first line is still first line treatment. And it is also growing the rule of EUS radiofrequency ablation. And this modality may be considered as a treatment options in patients with small, it means less than 2 centimeters insulinomas. Update in the surgery in gastrinoma. The treatment of choice for sporadic localized gastrinoma is a resection of the primary with systemic lymphadenectomy. But the timing and the type of surgery for MEN1 related gastrinoma should be individualized according to patients' characteristics and preferences. It's worth to know that it was for me very interesting that patient with pancreatic tumors that was not visible in imaging studies and who did not undergo surgery still have got a good prognosis with 5-year survival rates, 90%, and 10-year survival rate of 55% in cases of distant metastasis. And also very important that in addition, up to 85% of MEN1 gastrinomas are metastatic at the time of diagnosis, although the primary tumor might be very small, tiny microadenomas as small as 1 to 2 millimeters. The management algorithm for advances disease is present here, and this algorithm presents therapeutic options ranging from controlling hormone overproduction to antiproliferative treatment. This treatment includes, as you can see here, somatostatin analogs, PRT, chemotherapy, molecular therapies. It is especially important as PRT, you can see here, plays an increasingly important role in all new neuroendocrine tumors guidances. PRT move up higher and higher in many treatment algorithms. And also very nice therapeutic options among many new therapeutic options being studied anti-insulin receptor antibodies represent a promising treatment for patients with malignant refractory insulinoma who experience severe hypoglycemia despite traditional therapies like embolization, medication, diazoxide, everolimus, as well as PRRT. It is a very promising therapeutic option for malignant refractory insulinomas. And now I will move to the guidance paper for non-functioning pancreatic neuroendocrine tumors. It's worth to stress the occurrence of non-functioning pancreatic neuroendocrine tumors is genetic in genetic syndromes is relatively common. For example, about 80 to 90% of patients with MEN1 syndrome develop pancreatic neuroendocrine tumor with non-functioning variants, which is frequently observed. Usually they are often multiple, slow-growing, but they carry a significant risk of metastasis. And this genetics association underscores the importance of regular screening, early detection, as a non-functioning pancreatic tumors can also develop at younger ages and may have different progression risk than, for example, sporadic cases. In our guidance paper, as in previous one, there are 10 most important questions for clinical practice. In the second question concerned biochemical diagnosis, there is no routine circulating biomarkers for non-functioning pancreatic NETs. Still, chromogranin A determination may be useful in monitoring the course of the disease, but of course, high hopes have been placed on new molecular markers. Among them, very quickly, NET test has been reported superior to circulating chromogranin A, and it shows a significant advantage over other molecular biomarkers, because we can use this not only for the diagnosis, but also for monitoring disease, to assess also progression of the disease. But it is not widely available, which is why it is not included in this practical recommendations. The next question concerns the treatment of pancreatic neuroendocrine patient. Started with surgical treatment. Patient with asymptomatic non-functioning pancreatic NETs should undergo active surveillance. Decision to surgically treat tumors between 1 and 2 centimeters should be personalized. Also, what's new in the consideration in selected cases, we can use preoperative treatment with PRT in locally advanced pancreatic G1 and G2 tumors. There are publications confirming that we can use PRT as an induction therapy in locally advanced pancreatic neuroendocrine tumors. Another question concerns the role of PRT. This treatment modality may be considered as a second line of treatment with selected patients, but I have to stress that our guidance paper was published in the end of 2023. Before the results, we know the results of the first results of NETTER-2 study, which support the earlier use of PRT in treatment algorithm. There are many ongoing trials with PRT, more focus of combination therapies. Also, novel targets will increase the number of patients eligible for PRRT. For us, is very important. Maybe I will miss this regarding the role of molecular targeted therapy. We can use it also in NET-G3. Regarding chemotherapy, this treatment modality has been long used for patients with pancreatic neuroendocrine tumors. Our expert suggested the use of CAPTEM as an upfront treatment for patients with metastatic G1, G2 tumor, as well G3. In our Polish recommendation, we list the most commonly used chemotherapy regimens in pancreatic NETs, but to learn about the best chemotherapy regimens, I also encourage you to read the NETs 2023 guidance paper for digestive neuroendocrine carcinoma, which was prepared by a group of experts led by Professor Sorby. And very quickly, the next question is concern first-line treatment therapy and sequence of treatment in advanced disease. For somatostatin receptor positive patients, initial treatment is, of course, often called somatostatin analogs, afterwards PRT. For somatostatin receptor negative tumors, they're managed with targeted therapies, afterwards chemotherapy, which usually may be considered for cases with rapid disease progression. And also in our recommendation, we wanted to emphasize specific management for patients with MEN1. Even in selected patients with tumors between 2 and 3 centimeters in size, MDT may choose the use of active surveillance rather than surgery. And well, future diagnostic and therapeutic strategies for pancreatic neuroendocrine tumors, of course, will likely involve more precise molecular and genetic profiling. We have to focus on our international collaboration, advanced imaging, new biomarkers, and new targeted therapies. While waiting for the results of many conducted studies, we discuss each patient in MDT and decide on the best therapeutic option for the patient. A practical example of multidisciplinary board for rare disease is our National Polish MDT for neuroendocrine tumors. It held twice a month since almost 8 years, where any physician from whole country can discuss therapeutic options for their patients. Thank you very much. Okay, I will.
Thank you. Thank you, Beata, for your great presentation. I'm also impressed by the last few slides regarding the possibility to have a nationwide MDT, which is impressive because I guess it was very difficult for you to put on to start it. There is one question from the audience. Is there a role for octreoscan in SSR expression assessment before PRT?
Well, we are not using octreoscan anymore. Mainly we can usually use gallium PET CT, but also scintigraphy with technology. Maybe also Valentina would like to add something to these questions.
I think that if we are talking about gold standard, PET CT is the gold standard. But in centers who do not have PET CT, And in the presence of a metastatic disease that is highly avid of the radiopharmaceutical, SST could also be performed, I mean, for the assessment of the eligibility to PRT. Although we know that there are some, I mean, the expected accuracy of scintigraphy is generally lower, but in the patients who are addressed to PRT, the eligibility, as in the NETR1 study, could be driven also by scintigraphy. But if we want to move forward in the direction of the innovation and what is the best way to assess disease, PET-CT is certainly the gold standard option.
Yes, but we don't use octreoscan anymore.
No,
No
we don't use it.
octreoscan
No, not at all.
anymore.
Not at all. But I can imagine that the question was dealing towards the direction that in some guideline, there is still the statement of somatostatin receptor imaging that also includes scintigraphy. And I think this was done mostly to include the possibility to scan with scintigraphy in countries who do not have the access to SST PET-CT, which is the gold standard.
Yeah,
I think
that's
that
well,
was the only idea, but of course we stopped using Ultrascan in 2007, so a long time ago.
Okay, thank you.
I'm not sure if there are any more questions from the audience. I don't think so. Do you think we have time for another quick question or maybe not?
Yeah, probably it's
Probably we can.
6 p.m. that
6
we
p.m.
have
is
to,
probably
yeah,
6:01, and we are
yeah,
all afraid that the Zoom will
yeah, we
shut
have to
down
finish.
abruptly.
Yeah, we have to finish, but we would like to thank all people who attend this webinar. We would like thanks especially Ipsen for supporting us, especially SERP, and we would like to thank all ECE people who can help us with preparing this webinar. And thank you for nice questions, Valentina. Thank you for nice presentation. And I hope we will meet during the next webinar.
Sure. And thank you, Beata. There is just one quick question. How can we participate to Telenen? It's a question for you, I'm sure.
Well, it is for our Polish physician, but we can think how to participate also for people from abroad. Okay, we will be in touch and we will try to
Extend.
extend a little bit. That's true that we are dealing and preparing all this patient presentation since almost 8 years. Every single 2 weeks. It's a lot of work, but we would like
Can
to do
imagine.
more. Thank you. Thank you very much, and thank you for
Thank you for attending, and good evening to everyone.